Welcome to the Clinic Manager training for the Stop Flu at School program. This presentation will provide information about how to manage school-located influenza vaccination clinics. Let's begin with an overview of the role and responsibilities of the Clinic Manager. These can be divided into 3 phases: pre-clinic, operations, and post-clinic. Before the clinic begins, the manager will need to check in staff, oversee the setup of the clinic, provide just-in-time training, and perform a clinic walkthrough to ensure the setup is complete and flow is efficient. During operations, the manager will manage staff and ensure program procedures and protocol are being followed. The manager will utilize the management of acute adverse reactions to vaccines and document all incidents. After operations have ended, the manager will oversee clinic breakdown and complete all necessary forms. Students in kindergarten through 8th grade, who attend participating schools, are eligible for the Stop Flu at School program, but due to funding constraints, adults are not able to receive vaccine through this program. This includes school faculty and staff, and clinic staff. The following slides will provide information on the manager's pre-clinic duties. The clinic manager should check in at the school office 60 minutes prior to clinic start time, to meet with the school liaison and to check all supply boxes and vaccine coolers to ensure there are sufficient supplies and vaccine to conduct the clinic from start to finish. If any items are missing, use the telephone triage to contact the appropriate person at DOCD, for Oahu staff, or the district health office, for neighbor island staff. The clinic manager or vaccine group supervisor must check the vaccine cooler to ensure that the vaccine is cold, but not frozen. Vaccines should not be in direct contact with the cold gel packs. The vaccine should have been packed with temperature monitor strips. Check the monitors to confirm that the vaccine has not been frozen or exposed to excessive heat. Warm temperature monitors are pictured in the upper left-hand corner. The strip reading should not equal or exceed the number 3. A cold temperature monitor is pictured in the upper right-hand corner. The bubble should not be opaque and the check mark should be visible. There is an example in the picture of what is okay and what is frozen. If either monitor indicates that the temperature has gotten too warm or too cold, contact the immunization branch immediately. Do not administer the vaccine. The clinic manager should look at the expected number of participating students, found on the SFAS 204 form, and ensure the vaccine supply is sufficient for the clinic. The manager should also confirm that there is a sufficient quantity of lot number labels, and that the lot number on the labels matches the lot number of the vaccines. Because these are mass vaccination clinics, there will often be a need to pre-fill syringes. It is very important that the clinic manager and vaccine group supervisor oversee this activity to ensure that it is performed carefully, and vaccine is not wasted. Draw, or instruct vaccinators staff to draw, a maximum of 10 doses per multi-dose vial. Open the syringe package as syringes are filled, but not before. Store pre-fill syringes appropriately in vaccine coolers until needed, with a maximum of 20 syringes inside each soft cooler. Do not leave vials or pre-fill syringes exposed to ambient room temperature or light, as it could affect vaccine viability. There may be times when not all 10 doses are needed from a vial. The leftover vaccine is referred to as a partial vial. When this occurs, indicate the number of drawn doses on the vial and on the box. Then place the vial back in the box, and store appropriately in the cooler. The clinic manager is responsible for managing clinic staff and ensuring that everyone signs in on the 211 or 211V form. These forms will be discussed later in this presentation. School volunteers should sign in on the volunteer form. Please note that contract staff are not to begin working until their designated start time, even if they arrive early. Ensure that all vaccinators read the standing orders and initial in the column on the 211V form. Assign identification codes to the vaccinators. These codes are listed on the 211V form and will be used for documentation of vaccine administration. As needed, the clinic manager can assign personnel to act as supervisors of the registration station and line flow staff, as well as the vaccinators. The clinic manager will often need to assign roles within groups. For example, assign registration staff to screen forms, control line flow, or watch students in the observation area. If the observation area is in a separate room from the clinic, there must be an RN stationed to that room with an extra emergency kit. The clinic manager will also need to ensure all staff receive and review their job action sheets and provide standardized just-in-time training. Once just-in-time training has been conducted, staff must initial the 211 and 211V forms. Ensure that all staff understand their roles and duties. A school may have parent or school volunteers. These volunteers may not screen consent forms, but they may assist with line flow. They may assist trained clinic staff in the observation area, but they may not staff the observation area without an SFAS clinic staff member present. These volunteers must sign in on the volunteer form, not the 211 or 211V forms. The 211 and 211V forms are for trained clinic staff only. Advise clinic staff that any questions, issues, or adverse events must be reported to the clinic manager. It is mandatory that all staff must receive just-in-time training. Clinic managers will receive standardized forms to use for this purpose. Pictured here is the just-in-time training document that includes reminders for the clinic manager and all registration staff. Pictured here is the just-in-time training document that includes reminders for vaccinators. There must also be some on-site training for vaccinators. Demonstrate the use of the retractable syringe. Remind vaccinators to properly dispose of used syringes immediately following vaccination, to reduce the risk of needle stick injuries. Remind vaccinators to wash hands or use hand sanitizer between each patient. If gloves are worn, they must be changed between patients. Gloves must be worn if the vaccinator has open lesions on hands or is likely to come into contact with potentially infectious body fluids. Remind vaccinators that participants with a screening question that is marked yes should not be vaccinated, even if they have a doctor's note. Ensure that all vaccinators review the standing orders and are familiar with the emergency kit contents and its location. The clinic manager will look at the space provided by the school, determine the clinic flow plan, and oversee the setup of the clinic. The observation area should be within the clinic, near the vaccination stations, and within sight of the clinic manager. However, this isn't always possible. If the observation area is in a separate room, make sure to add one emergency kit and an RN to that observation area. Participants must be seated during observation to reduce injury if fainting occurs. The observation area must be large enough to allow vaccinees to be seated. If possible, have students sit on the floor. The clinic manager must perform a clinic walkthrough before operations begin, to check that flow will be efficient. Once the staff have been briefed and the clinic is set up, operations can begin. Ensure the clinic starts and ends at the scheduled time. Record clinic times and the school ID number on the SFAS 204 form. The end time is when the clinic is completed. Communicate with the school liaison to escort students to and from the clinic. Note that the liaison must bring the last group of students to the clinic 20 to 30 minutes before the clinic end time, to allow for vaccination and the 15-minute post-vaccination observation period. This is dependent on group size, room size, and number of vaccinators. The clinic manager will oversee all clinic operations, maintain a steady pace, identify bottlenecks, and make appropriate adjustments. The clinic manager will ensure the safety of all participants and clinic staff, and will follow up on forms as needed. The vaccine cold chain must be maintained at all times. Excessive light, heat, or cold exposure damages vaccine, resulting in loss of potency. Ensure that vaccine is stored in vaccine coolers or at the vaccination stations in soft-sided coolers with contents layered. The vaccine must always be packed in layers for insulation and to keep the appropriate temperature. This is true of the large holding coolers and also of the soft-sided tabletop coolers. The layers are as follows: ice packs, also referred to as gel packs, on the bottom, then a barrier, such as bubble wrap, then the vaccine, more barrier, and then another layer of ice packs. Pack vaccines including the partially used vials inside the boxes on top of the barrier, so that the vaccine is not in direct contact with the ice packs. Ensure that the warm and cold temperature monitor strips are placed next to the vaccine and not in contact with the ice packs, or it will give an inaccurate reading. Ensure proper disposal of all hazardous materials. All vaccinators must place used syringes in the sharps containers immediately after administration. Hazardous materials should not be accessible to non-clinic personnel. The clinic manager will address apprehensive students before vaccination. If the student is still apprehensive or crying, have a secondary person, such as the health aide or flow control staff, stay with the child during vaccination. Do not restrain the child for vaccine administration. If safety becomes an issue, do not vaccinate. The clinic manager is also responsible for responding to and managing adverse events. Address students with incomplete consent forms or potential contraindications. You may need to complete the bottom portion of the parent-guardian notification half sheet. This form goes home with each student. If they are vaccinated, it is indicated. If they are not vaccinated, indicate the reason on the bottom half of the form. If the child is not vaccinated, please indicate the reason on the parent-guardian notification form. Reasons may include incomplete consent forms, when a question is left blank, or the parent or guardian's signature or date of the signature is missing. It also includes contraindications to immunization, which would be indicated if any question on the consent form was answered yes. Complete the parent-guardian notification form if the student feels ill, or has a fever, if the student refuses the vaccination, or for any other reason that would result in the child not being vaccinated. To complete the parent-guardian notification form, record the student's name and the clinic date. Indicate the reason the student did not receive the vaccine. Retain the original copy of the student's consent form. Indicate the reason for not completing vaccination on the bottom of the consent form. And provide the parent-guardian notification form to the student to take home to the parent. The clinic manager must ensure proper completion and collection of all consent forms. All vaccinations must be fully documented on the bottom of each consent form. No missing information. No missing lot number labels. And the ID code matches the vaccinator's assignment on the 211V form. Remember, do not affix lot number labels to consent forms for persons who were not vaccinated. The clinic manager will oversee the management of any adverse event post-vaccination. Follow standing orders for the management of acute adverse reactions to vaccines. Call 911 immediately for any serious adverse event. Notify the Department of Health, Immunization Branch, of any serious adverse event within 2 hours of occurrence. Once the clinic has concluded, the clinic manager will supervise the clinic breakdown, staff checkout, and forms completion. The clinic manager should ensure proper retrieval and packing of all hazardous waste products. appropriate packing of all remaining supplies, collection of all consent forms, delivery of supplies to the Department of Health or other designated location, and return of the clinic site to its original condition. All remaining vaccine should be returned in the same manner that it was received. Vaccine cooler contents should be layered: ice packs, barrier, vaccine, barrier, and ice packs. Ensure the vaccine and monitors are not in direct contact with the ice packs. Ensure sharps containers are not filled beyond the maximum fill line. Close, lock, and tape all sharps containers, even if only partially filled. If transporting sharps containers in a non-leak-proof box, line the box with a large biohazard bag. Place closed, locked, and taped sharps containers into the line box. Tie off ends of the biohazard bag. Then secure tie off with tape. Cover the box with a lid, secure with tape, and affix the biohazard symbol labels to the box. Transport boxes containing sharps containers in an enclosed vehicle compartment, like the trunk of a car, and ensure the biohazard symbol placard is displayed on the transport vehicle's dashboard. Pictured here is the SFAS 204 form. Complete this form with summary figures, the clinic's start and end time, and any relevant notes. The clinic manager's name and the date must also be included. Pictured here is one of the sign-in sheets. Ensure that all staff have signed in and out, and that the clinic's start and end times have been indicated, as well as the school name and ID number. Send the original 204, 211, 211V, and any volunteer sign-in forms to the immunization branch, along with the consent forms, supplies, and vaccines. Lastly, notify the school liaison of the clinic's conclusion and ensure staff sign out on the log in the school administration office. In this section, the school-located influenza vaccination program's standing orders for the management of acute adverse reactions will be reviewed. All vaccinators and clinic managers must review, understand, and adhere to the Stop Flu at School program's standing orders for inactivated influenza vaccine, and the protocol for the management of acute adverse reactions to vaccines. Personnel administering vaccines, and clinic managers, must be aware that recipients may experience an adverse reaction following immunization, which can be life-threatening. Clinic managers need to be prepared to recognize and respond immediately and appropriately if an adverse reaction should occur. When assessing persons with possible adverse reactions post-vaccination, follow basic first aid and initial assessment procedures. Check their vital signs: airway, breathing, including both their respiratory rate and air movement, and circulation, including pulse and blood pressure. Evaluate their level of consciousness and appearance. Are they alert? Do they appear comfortable? Are they able to speak? Do they seem anxious? Persons that are anxious when receiving a vaccination may hyperventilate. Symptoms of hyperventilation include rapid breathing with good air movement, no wheezing or stridor. The patient appears anxious, but not tired or pale. They may complain of lightheadedness. They may have weakness, numbness, or a tingling sensation in the arms or mouth. They may have muscle spasms in the hands and feet. To manage hyperventilation, make sure the airway is clear. Instruct the patient to sit or lie down and slow down their breathing. Have the patient breathe into a paper bag to correct the hyperventilation. Provide support and reassurance. And monitor the person until the episode subsides. Symptoms of lightheadedness include fright before the vaccination is given, complaints of feeling faint, dizzy, or tired. The patient appears pale. He or she may be yawning. The pulse is steady, and there is no respiratory distress. To manage lightheadedness, Have the patient sit or lie down for the vaccination. Have the patient lie flat or sit with their head between their knees for several minutes. Loosen any tight clothing and maintain an open airway. Check their vital signs, including pulse, blood pressure, and respirations. And apply cool, damp cloths to their face and neck. Symptoms of syncope or fainting may include extreme paleness, sweating, cold hands and feet, nausea, lightheadedness, dizziness, weakness, visual disturbances. Vital signs are normal, the person should be breathing normally. Respirations may be shallow, but there should be no respiratory distress. Pulse is regular. They may fall, without loss of consciousness. Or they may lose consciousness. To manage fainting, have the patient lie flat or sit with their head between their knees for several minutes. Loosen any tight clothing and maintain an open airway. Check their vital signs, including pulse, blood pressure and respirations. Apply cool, damp cloths to their face and neck. If the patient loses consciousness, examine to determine if an injury is present before attempting to move the patient. Place the patient flat on his or her back, with feet elevated. Call 911 if the patient does not recover immediately, or if an injury is present. Once consciousness is regained, observe the patient in a quiet area until they are asymptomatic, for a minimum of 15 minutes. Severe, life-threatening anaphylactic reactions following vaccination are rare, estimated at about 1 in a million doses. Anaphylactic or allergic reactions may be due either to the vaccine or a vaccine component, and may be severe and life-threatening. The risk of an allergic reaction can be decreased by thorough screening for contraindications and precautions prior to vaccination. However, even with careful screening, reactions may occur. Staff and clinic managers should be familiar with the signs and symptoms of anaphylaxis, because allergic reactions may begin almost immediately after vaccine administration. Anaphylaxis requires rapid recognition and treatment to prevent progression to cardiovascular collapse. Signs and symptoms of anaphylaxis can include but are not limited to generalized hives, itching, erythema or redness, flushing, swollen lips, face, throat, tongue, or uvula, shortness of breath or dyspnea, wheezing and bronchospasm, stridor, hypoxemia, abdominal pain or cramping, vomiting, diarrhea, reduced blood pressure, syncope or fainting, cardiovascular collapse, hypotonia, and incontinence. Every clinic must have an emergency kit containing epinephrine, both autoinjectors and aqueous epinephrine in ampules and/or vials, diphenhydramine, supplies for administering medications, including filter needles for drawing epinephrine from the glass ampules, child and adult blood pressure cuffs, stethoscope, pediatric and adult resuscitators, and other supplies. If a patient has symptoms or signs of anaphylaxis, call 911 immediately. Assess their airway, breathing, circulation, and their appearance and level of consciousness. Place the patient in a recumbent position. Make sure their airway is clear. Use manual resuscitator if necessary. If no pulse, begin CPR. The first and most important therapy in anaphylaxis is epinephrine. There are no contraindications to epinephrine in the setting of anaphylaxis. Each emergency kit will have a pediatric and an adult epinephrine autoinjector that may be used for rapid administration of the initial dose. Administer aqueous epinephrine 1 to 1000 intramuscularly. The dose for epinephrine is 0.01 ml per kilogram per dose. If the weight is known, then dosing by weight is preferred. If the weight is not known or not readily available, a chart included with the standing orders and in the emergency kit has approximate dosages for children, based on age and weight. The maximum dose for children is 0.3 milliliters. The maximum dose for adolescents is 0.5 milliliters. For generalized hives or itching, diphenhydramine may be administered by intramuscular injection at a different site than that given for the epinephrine. The standard dose is 1 to 2 mg per kilogram, with a maximum single dose of 50 mg. If the weight is known, then dosing by weight is preferred. If the weight is not known or not readily available, a chart included with the standing orders and in the emergency kit has approximate dosages for children, based on age and weight. The patient should be monitored closely until EMS arrives. Perform CPR or assist with respiration if necessary. Keep patient in a supine position, flat on their back, unless the patient is having breathing difficulty. If breathing is difficult, the patient's head may be elevated, provided blood pressure is adequate to prevent loss of consciousness. If blood pressure is low, elevate the legs. Monitor vital signs every 5 minutes. If EMS has not arrived and symptoms are still present, administer epinephrine dose intramuscularly every 5 to 15 minutes or more frequently as necessary to control symptoms and maintain blood pressure, up to 2 times after the first dose for the treatment of anaphylaxis. Monitor and record all signs and symptoms, vital signs, medications administered, including the time, dosage, site, response, name of person who administered the medication, and other relevant clinical information. All patients showing signs and symptoms of anaphylaxis, regardless of severity, should be referred to an appropriate medical facility for treatment. If EMS is called, and the student is transported to an emergency facility, the clinic manager must complete the referral to emergency facility form, in addition to the incident adverse event reporting form. When should you complete an incident adverse event reporting form? Fill out the form for any adverse reaction, including lightheadedness, headache, or itching. Any person who was vaccinated twice. Participants with contraindications who received vaccine. Mistaken identity of a participant, when someone received the vaccine using another person's consent form. Document any incident or unusual occurrence. Please include a copy of the consent form, not the original, with the incident report. Please complete all reports on the day of the incident, so that the details are fresh in your mind. But don't feel as if you must complete the incident report during the clinic. It is fine to return to your office to complete the report. If you complete the incident report prior to the end of the vaccination clinic, you may submit the report to the immunization branch with the consent forms. If the report will not reach the immunization branch on the day of the incident, please fax the report to 808-586-8312. Please be aware that incident reports and forms may be read and reviewed by upper management and by agencies and individuals outside of the Department of Health. Please remember, when documenting incidents, be thorough, but succinct. Be specific. Be objective. Be professional. This form includes several common errors that we see on the incident adverse event reporting forms. The form is missing information, such as the student date of birth and the school name. In this example, the patient's blood pressure is very low and there is no documentation of repeat blood pressure checks, or any explanation of the actions taken. The final disposition states, went home with mother, without any documentation of improvement in the patient's condition. In this example, the patient moved during administration of IIV. If a student does not receive a full dose, the parent must be contacted before a second attempt at vaccination is made. This form is marked, Parent contacted, No. In this situation, the parent should have been contacted for permission prior to attempting a repeat dose. Note: the action taken section, including steps taken to prevent recurrence, does not need to be completed if there is no action that could have prevented the incident. Now we will review the procedures for responding to bloodborne pathogen exposures. If a person is exposed to bloodborne pathogens at a school-located influenza immunization clinic, treat the exposure site immediately. Wash needle sticks and cuts with soap and water. Flush splashes to the nose, mouth, or skin with water. Irrigate eyes with clean water, saline, or sterile irrigants. Report any bloodborne pathogen exposure to the clinic manager. Any person exposed to bloodborne pathogens at the school-located clinics should immediately seek medical treatment. Contract personnel should be referred to their employer. Military personnel should be referred to the Department of Defense. Public Health Nursing Branch staff should be referred to the PHN branch. Medical Reserve Corps volunteers should be referred to the MRC coordinator. Kaiser personnel should be referred to their employer. The clinic manager should record the circumstances and post-exposure management on the Incident Adverse Event Reporting Form. The report should include the date and time of exposure, post-exposure management, details on the procedure being performed, including where and how the exposure occurred. If the exposure is related to a sharp device, include the type and brand of the device, and how, and when, in the course of handling the device, the exposure occurred. Include details of the exposure, describing the route, for example, mucosal, percutaneous, etc., type and amount of fluid or material, and the severity of exposure. Provide details about the exposure source, including the name and parent and guardian's name if the source is under 18 years of age, address and telephone number. List the exposed person's name, address, telephone number, hepatitis B vaccination dates, and vaccine response status. Call the DOH immunization branch to report the exposure. In what situation should a parent be called? If the student has a consent form but states that he or she has already been vaccinated, contact the parent to confirm. If the student pulls away during administration and receives no dose or only a partial dose, contact the parent to ask if they would like you to attempt vaccination again. If you are unable to contact the parent, do not revaccinate. When there are questions left blank on the consent form, if the clinic is very busy, the clinic manager does not need to call for this situation. However, the student should not be vaccinated. If there are contraindications to vaccination, to explain that the student will not be vaccinated. Again, if the clinic is busy, the clinic manager does not need to call in this situation, but the student should not be vaccinated. When the date of the parent or guardian's signature is missing, if the parent or guardian is contacted, document their consent to date the form. Also, parents should be contacted for any adverse event, and any time a repeat dose is necessary, to request permission to revaccinate. Persons with adverse events post-vaccination at a previous stop flu at school clinic will be listed on a green sheet, which will be packed with the ICS forms. The list will include the names of persons who should not be vaccinated at a stop flu at school clinic, and those who may only be vaccinated with a doctor's note. General information about forms and instructions related to staffing will now be provided. The number of staff per clinic is typically based on several factors, including total number of participants based on the total number of consent forms collected per clinic, total number of clinic hours as per the clinic schedule, and the standard minimum number of vaccinations that can be administered per hour, which was determined by a time study conducted in previous stop flu at school clinics. The number of staff determined for each clinic can be adjusted as needed, at the recommendation of clinic managers, to ensure sufficient staff is provided for each clinic. For Oahu clinics, A list providing the total number of staff assigned per clinic will be posted on SharePoint 1 week prior to the clinic start date. There are two separate and unique forms used for documentation of assigned clinic staff and attendance, and serve as sign-in sheets for each clinic. The SFAS ICS 211 is used for all registration staff, including line flow personnel. The ICS 211V is for vaccinators, including the clinic manager and vaccine group supervisor. Both of these forms will be provided on the day of clinic and will be located in the ICS packet. For Wahoo clinics, both the 211 and 211V forms will be pre-populated with information such as clinic name, date, and time, names of assigned staff, their role, and affiliation. The 211V forms are for vaccinators and will include the clinic managers and vaccine group supervisors. The fill-in columns on these forms will include sections where the assigned staff will verify by initialing that they have received just-in-time training and reviewed the standing orders. There will also be spaces to enter their time in and time out. On the 211 and 211V forms statewide, clinic managers and vaccine group supervisors will need to complete specific attendance status information, such as staff that are late or no-show, or staff who are a replacement for a no-show. Refer to the key at the bottom of the sign-in sheets. For Wahoo clinics, sign-in sheets will also include a note section to indicate when additional or early staff were requested and provided, such as when an RN is requested 1 hour early, when an extra RN is requested for the holding or wait area, or when an extra registration staff is requested. This is an example of a 211 sign-in sheet for registration staff on Wahoo, with pre-populated information. At the top, you can see the school name, school ID, and the scheduled time and date of the clinic. The names of assigned clinic staff are pre-populated, as well as their affiliations. Note that SR1 and SR2 designations for the supplies return persons will only be used in the event that a supplies return person is needed and assigned. The form also includes fill-in columns for clinic staff to initial that they have received just-in-time training, and to enter time signed in and signed out. There is also an attendance status column for clinic managers to document staff who are late, a no-show, or a replacement staff. The key with the attendance status abbreviations is located in the lower left-hand corner. This slide shows the note area with an example of an extra registration staff provided. A note may also indicate when an assigned RN will arrive 1 hour early, as requested by the clinic manager. This is an example of the ICS 211V form for vaccinators on Wahoo. It looks similar to the ICS 211 form for registration staff, but includes an additional column where staff will initial that they have reviewed the standing orders. It also includes a column with pre-populated unique vaccinator ID codes. Changes in assigned staff may occur up until the morning of the clinic, and therefore may not be reflected on the sign-in sheets. Clinic managers should refer to the published list of approved SFAS personnel to verify eligibility of a person reporting to clinic, whose name is not pre-populated on the sign-in sheets. This list is located in the Go Kit with the ICS packet. Note that the approved registration staff are listed first, followed by the approved vaccinators. Both lists are in alphabetical order. This sign-in sheet demonstrates how to document when there are last-minute changes to the staffing of a clinic. The clinic manager may or may not be notified of any last-minute changes in staff. In this example, 2 registration staff, Marilyn Manson and Marianne Gomez, are listed as assigned staff, but are crossed off because they were reassigned or cancelled last minute. The staff now assigned to the clinic are Lindy Lou and Harry Potter, and their names should be written in, along with their affiliation. This is an example of documentation for a situation where an assigned staff did not show up to the clinic, and another staff was sent as a replacement. Britney Spears was the no-show, and NS is written in the attendance status column to indicate this. Because Britney was a no-show, the clinic manager requested a replacement staff from the vendor. Katy Perry was sent as the replacement staff, so her name and affiliation were added to the list. Her designation as replacement staff is noted by the RP in the attendance status column. Notice that Katy Perry's sign-in time is after the required start time, and she would have been considered late if not for the RP designation in the attendance status column, which indicates that she was a replacement staff. Because there are disciplinary actions for staff who are repeatedly late for clinics, the RP designation in the attendance status column is very important. This is an example of documentation of a staff who is late to a clinic. On this form, Marianne Gomez's check-in time is 8:10. Because she was late, an L is entered in the attendance status column. If you need assistance, please refer to the Stop Flu at School telephone triage list for contact information. Contact the staffing vendor directly if contract staff are late or no-show, and also to request replacement staff for late or no-show persons. Contact immunization branch staffing coordinators if volunteer staff are late or no-show. For clinic role reassignments, for example if you need to change registration staff to vaccinator staff, and other requests, you must call the DOH staffing coordination team. Late staff, no-shows, and partners staff contributions will be tracked using the personnel check-in or sign-in and sign-out information. Ensure that all clinic staff sign in and sign out. If time-in or time-out information is missing or unclear, you will be contacted to verify. This is the Personnel Action Reporting Form. When should you fill out a personnel reporting form? When any action, performance, or attitude of clinic personnel requires the aid of upper management to resolve, or, at minimum if it merits review and documentation for future reference in staff training or development. Examples of reportable personnel issues include safety issues, which threatens the safety of students or staff, insubordination, which interferes with the efficiency of the clinics, attitude issues, which undermines the authority of clinic managers and the overall safety of the clinic. All personnel action reporting forms will be reviewed by the DOH Immunization Branch SFAS Management Team, and forwarded to Public Health Nursing Branch Management, and the appropriate staffing organization or agency. The personnel action reporting form may be completed by the clinic manager or the vaccine group supervisor. If completed by the vaccine group supervisor, it must be reviewed by the clinic manager. Complete this form as soon as possible, while pertinent information is fresh in the minds of all individuals involved. Submit the form as soon as it is completed. Reports and forms may be read or reviewed by agencies and individuals outside of the Department of Health. Please remember, when documenting information on the personnel action form, be specific and detailed, but succinct. Be objective and professional. This concludes the clinic manager training. Please document your completion of this training on the sign-in sheet. If you have questions regarding the content of this training, please contact the immunization branch at 586-8300 on Oahu. Calls from the neighbor islands are toll-free at 1-800-933-4832 or email schoolflu.helpdesk@doh.hawaii.gov. Thank you for watching this webinar. Your work as clinic managers is invaluable and much appreciated. Thank you for supporting the Stop Flu at School program.